my title says I'll be talking about computerized decision support tools to reduce wasteful inpatient lab utilization. The majority of my academic area of interest is actually in patient safety, but in the last few years as I've worked more on with IT services, I've gotten much more interested in value because I'm convinced these are some of the tools that are going to help us improve the value of the care that we provide. And I'm really pleased to be here with you all, in part because I've had such excellent collaborations with a large number of your faculty now. So Noah and Brian, Jeff Baird, Dan Sabbath, Andy Hufenagel, Susan Butler-Wu, have all been involved at one point or another in some of these projects or projects that eventually led to this work. So I've learned a ton from you, and I hope I can return some of the favor. Here's an overview of what I'll talk about. I'll give some economic background quickly to set the stage for why this work is so important and what the national issues are that are driving our local behavior. And then I'll go through a series of case studies of either problems we've encountered at UW Medicine or the solutions we've created to try to address them and to try to pull some of the principles out for what's next in this area of work. And I'd like you to take away from this, first of all, the ability to associate some national trends in healthcare costs with the challenges we're facing at UW Medicine, to describe the pros and cons of some different decision support mechanisms, and I'll advocate that there's definitely not a one-tool-fits-all kind of approach. We really have to have tailored solutions to these problems. And ultimately, what I think is in it for you in this talk is that I'd like to seek more collaboration with lab medicine for IT services to help clinicians learn from your expertise to be ordering the right tests when we're out there on the wards. So I'd welcome any ideas and opportunities that come from this. So this probably won't be a big surprise to many of you, and I think in fact in the last year you've had some speakers who talked about healthcare financing, but just to reiterate what a problem we have as a country, we're spending an enormous amount of money on healthcare. In 2012 it was almost $3 trillion, about $9,000 per person. It consumes a major chunk of our GDP. And because of all the baby boomers who are retiring and needing health care and the expansion of insurance with Medicaid, we're actually on track, despite a lot of reform efforts, to probably spend about $4.5 trillion per year on health care in 2021. And that's pretty alarming, but what's really upsetting about this is that about a third of this is wasted. This is a pretty consistent figure when you look at estimates from lots of different healthcare economists. And the fact that we're diverting over $1 trillion away from other really important things that our society needs, education, infrastructure, personal wealth, whatever it is that we could be doing with this money, it's instead going to healthcare and it's not delivering better health. And this is really catching the attention of our nation's leaders in a wide variety of stakeholder groups who are determined to try to deliver more cost-effective care in the US. This is a really tough problem, but a lot of the regulations and incentive mechanisms that are being brought to bear on hospitals like ours are really changing behavior. And here at UW Medicine, we're actually under a lot of pressure now, much more than we were 5 or 10 years ago, to improve the value of the care that we provide. And by that I'm referring to keeping the quality the same or higher and doing that at lower cost wherever possible. And an example of where the rubber really hits the road is our Accountable Care Network contract with Boeing. We're not going to exit that in a financially viable way unless we can become more efficient. And so our leaders are looking to our clinical services to find millions of dollars of new savings every year, in addition to preserving the ones we found in past years indefinitely, or at least for the next decade or so. So this is a really substantial challenge at a local level. And the good and bad news is there's still a lot of low-hanging fruit in our system. This is a graph of our cost index over the last about 4 or 5 years. I don't have all the Harborview data up through the present, but this is a ratio of the amount of money we spend to deliver care to a given patient over the expected costs. And those expected costs are really rigorously risk-adjusted through a comparison mechanism provided by the University Health System Consortium, or UHC. So if we have a ratio of 1, we're spending the same amount as the average academic medical center in the US to deliver care for that kind of patient. And then we aggregate all of our patients' scores. And what you can see is that in 2011-2012, UWMC and Harborview were spending 25 to 40% more per average patient than academic centers around the country. And although we're catching up, just as our peers are becoming more efficient, we're still about 16%, or we're spending about 16% more to deliver the same care that you might get at UCSF or Vanderbilt or Michigan. So there are clearly opportunities out there. So what's the contribution of our lab utilization to this problem? This is a slightly different figure. This comes from Pam Pelagia, our Chief Financial Officer, who looked at our lab costs per case mix index adjusted discharge. This is a way that Medicare uses to try to make all patients about the same level of complexity. So we take care of very complex patients here. We have a case mix index of about 2.1, one of the highest in the country. So the actual dollars spent per patient would be about double what you see here. At Harborview, it's about 1.9, also a hospital with an extremely complex patient population. But what you can see is that especially UWMC is really an outlier. When we compare ourselves to other academic centers, we're in the 90th percentile on lab cost per patient, and this is not 90th percentile isn't good. That we want to be in the low range here. And Harborview performs slightly better, but it's still an outlier. And when you look at what UHC thinks our excess spending on lab use it amounts to about $2 million per year across our two centers. And I realize this may be a sensitive topic. I am not at all an expert on how to run a lab. And I just want to be clear that going forward, I'm going to make the assumption in the rest of this talk that the lab is the most efficient mechanism in our, or set of people and processes in our hospital. And that what's driving this are people like me, the clinicians ordering too much of the wrong thing up on the floor. Okay, so that's sort of the, yeah.
Is this the actual cost of operating the labs, or is this the cost of lab tests billed to patients?
This is the cost, so this is not the charge. So we dump all of our cost data to UHC, and all of our administrative data about what our patients were, what their diagnoses were, and they crunch that and they come up with these numbers. So they have
FTE, supplies and equipment basically?
Yes, yeah. You can if you ask Pam, she can subdivide it out by those specific categories as well.
And I just want to say this also includes pathology. It's all bundled into one, I'm pretty sure.
Okay. The question is, does this include pathology? I believe that's the case. I would have to double check with Pam.
From my work, I'm the administrator for the department.
Okay.
My work with the hospitals, this would include pathology, just because we're all bundled together in the data set. Okay. Thanks.
So, as we look at this from the standpoint of what are physicians and other practitioners ordering that might not be necessary, I think it's helpful to have some perspective on a theoretical model of why are physicians ordering things that they don't need. And I'll offer a handful of theories or explanations. The first two relate to the culture in which we practice. And at an academic center, at least historically, people who were able to, trainees in particular, who could generate a lengthy differential and order tests for all of those things, were rather than being told that wasn't necessary, they were celebrated for their comprehensiveness and their fund of knowledge, right? I think that sort of attitude is passing by the wayside, but I would say that what I observe on the wards is there's still a lot of tolerance for the idea of letting trainees explore their own way, right? That letting them order extra tests to kind of figure out what works and how they should use a test, rather than directly supervising it at the moment they're ordering it, is sort of a mentality that remains pervasive. Defensive medicine, although not something we talk about on the wards a whole lot, it is a presence. I know from a survey performed, published just this year, of hospitalists at 2 community hospitals and 1 academic center in Massachusetts, demonstrates this, where the researchers presented to those hospitalists all the tests and medicines they had ordered in the preceding day and were asked to rank, was this not at all, somewhat, or completely driven by the practice of defensive medicine? That is, a test or procedure ordered to basically avoid litigation with no expected benefit to the patient. And in the survey, 28% of tests had some, at least partial or complete, motivation of defensive medicine. About 3% were completely motivated by no expected benefit to the patient, but protection of my own sort of legal exposure. And in total, this amounts to about 13% of the costs on that particular day in Massachusetts. So it is a concern, and it lowers the threshold at which providers are willing to order something to address uncertainty. And we may be uncertain about a lot of things. We certainly don't know as well as you all how tests perform. We often don't have or don't use pre-test probability calculators about a clinical condition. And we're also very uninformed about the costs of tests. We know from surveys of hospitalists in Washington state that only about a quarter of us can identify the cost of very common things, chest x-rays, CBCs, Chem7s, within a 30% margin of error. And it's not transparent. If you want to look this stuff up, you could find the Medicare charge info on the online test guide, but otherwise it's not at the point of care. And so you really have to be interested to go digging. And it's in this context, in this sort of cultural milieu, that the system of order entry does or does not help us to make the right choices. Part of what is missing from the system currently is lack of feedback about the choices that we make, although there are some improvements being made in that area. I know you just heard from Patrick about that. I think one of the biggest issues is the out-of-the-box design of Cpoe. We basically loaded a catalog of 10,000 different drugs, tests, consults, and other orders into a search engine that doesn't prioritize them in any way. And so things that were avoided previously now are given equal weighting to physicians who don't know what they're looking for. And it goes past that. I think one of the other issues is that we don't have great decision support across the broad array of conditions and problems that clinicians face. I do want to highlight something that's fortunately not on this map, and that's our payment system, which drives a huge amount of what we do in U.S. healthcare. And the good news is whereas the fee-for-service system in outpatient care that drives a lot of unnecessary procedures and surgeries doesn't apply in the inpatient setting. Our prospective payment system means that we actually we're going to be losing money as an institution if we order too many tests. And so it's in our best interest to be parsimonious. The other thing that's maybe showing the way a little bit is that professional societies have started to produce a very rudimentary roadmap for how we might avoid waste. And not all these deal with lab utilization. A lot of them actually deal with radiographic utilization. But just from my own specialty, the Society of Hospital Medicine has produced one of their top 5 choosing wisely recommendations is don't perform repetitive CBC and chemistry testing in the face of clinical and lab stability. So in other words, stop doing all those daily labs. This sort of advice is great insofar as it reflects that societies and the medical community at large is taking this seriously. I think part of the problem that we now face is that there's no specific guidance about how to implement these. And also, I think the impact of 5 things to avoid is questionable. They picked things that were as avoidant of controversy as possible. We already knew we should be doing this. And so it doesn't really lay out any new groundwork, but it does provide for the public and for administrators some set of benchmarks of what we should be watching for. But I think this isn't, we're going to need to do hundreds or thousands of these throughout our medical practice to really chip away at the waste that we see. And I think that decision support tools are the way that we're going to actually implement that in most care settings. So that we're all on the same page, a definition I like of clinical decision support systems is any electronic system to aid directly in the clinical decision making in which characteristics of individual patients are used to generate patient-specific assessments of recommendations that are then presented to the clinician for consideration. And the main thing here is that it's tailored to the patient's needs as much as possible. And what I would advocate is that when you're tailoring your medical decision-making and diagnostic workup to the patient's specific conditions, you're most likely to pick the tests and treatments that are going to benefit that patient and start to avoid waste and improve value. But one of the things that we're encountering frequently as we implement this is that they must be friendly to the physicians as well, because we actually have to adopt their use. And this is a really vexing problem throughout EHRs. But let me sort of outline what these tools might look like. This list here is kind of how I think of our toolbox. The one that everybody jumps to is alerts and reminders. These are really exciting insofar as on paper, we just couldn't do anything like this. We couldn't create tailored real-time interventions. The problem with them is they create a lot of alert fatigue and physicians start to ignore them. Depending on how firm their endpoints are, they frustrate clinicians by robbing them of autonomy, which might be appropriate in some circumstances, but when it's actually blocking the appropriate testing, it creates a lot of headache. And they're hard to implement, and I'll talk more about that as we go on in the talk. One other tool that we really didn't have on paper, or at least didn't have with the same level of sophistication, is reports and dashboards. And our Amalga tools have made this a near real-time possibility to deliver passive information to teams or to individual clinicians. But the problem when you don't interrupt somebody, which is the way an alert works, is that you have to count on somebody who cares about that report and is going to go check it. And we've built reports that nobody goes to, and that's sort of a waste of effort. So this has its use, but it's not appropriate in every circumstance. You have to really build the quality improvement infrastructure that's going to support it. Pathways and power plans are another way to influence physician ordering behavior. The nice thing is they're inexpensive, relatively speaking, and they're familiar. In most cases, we just replicated what was on our paper order sets with our power plans at Cpoe Go Live. The problems with these are that they tend to be static. We now have some tools to make them dynamic, but you have to strike a balance with how much information goes into them. If you put a lot in, physicians won't read it. If there's not enough, it doesn't explain why the steps are important or which ones should be taken. And ultimately, they're really easy to circumvent. If somebody doesn't like what's in that order set, they'll just go order what they want out of the search box. The last two, the next one really relates to the preceding one, which is the embedding of passive cost or guideline info into the orders. And we've actually seen now some nice randomized trials, at least in the outpatient setting, that just displaying the cost of lab tests does influence physician ordering behavior away from waste. The problem here is that Cerner really just doesn't support this. Or if we were to create a workaround, the maintenance costs and the data input to explain what our test costs would really be unsustainable. And the last category of decision support really has to do with the fundamental design of the EHR itself. It's really about how usable is this for clinicians, and does it create a pathway of least resistance to doing the right thing? This is really not a specific intervention, but a human factors engineering-based approach to what are the visual features, what are the options, what are the responses, how reliably can I get what I want with the fewest number of clicks. And the science that would support this is really nascent. It's not the way we see in aviation, for example, where a Boeing cockpit and a Airbus cockpit look the same, and there's tactile, auditory, visual feedback going to that pilot so they can, when they're in an emergency, do the right thing without having to think about it. In fact, our vendors are trying to build products that don't at all look alike and may not actually look like what clinicians want. So these are the tools that we have to solve the problems in front of us, and now I want to switch to some of what are the problems that we've seen at UWMC, and how did we go about analyzing them? And I'll do this in a little bit of a case-based format. So imagine it's the day after Cpoe went live at UWMC. You're the lab medicine resident on call, and you're getting numerous complaints from specimen processing that they're handling a high volume of duplicate orders. This really happened, as probably many of you are aware. And imagine you ask yourself, is this really duplicate orders that are mistakes, or did actual ordering increase? That is, did the unrefined user interface of Cpoe, say with pre-selected lab tests, or pick lists where interns are prone to just click everything and sort out the results later, did that lead to an expansion in use just because of the sort of the raw appearance of Cpoe? And with the help of Noah Hoffman, we tried to answer this at a very high level. This is a tree plot and heat map with the utilization of all of the lab tests in the catalog in the 6 months before and 6 months after Cpoe go live just at UWMC. And the box plot size is the volume of that test's utilization. So you can, and I'm sorry, I tried to strike a balance here between having text on the boxes and making that text readable. But I think now that it's projecting, you may not be able to tell what they are. In the upper left, that's glucose point of care. Then you have basic metabolic panel below that. So high volume tests, as you would expect, occupy the large boxes. And then the color represents the percent increase or decrease from the 6 months before to after go live. And I'll tell you that although I didn't adjust for patient-specific factors, the patient volume was basically identical in those 2 6 months. And what I want to point out here is that among the high volume tests, and I'm not going to go into the specific numbers, but the basic message is that high volume testing actually didn't change very much as a result of Cpoe. And I'll highlight a couple of exceptions to that, but most things fell into this category where you had something like a small increase in BMP use and a small increase in LFT utilization and a corresponding drop in CMP utilization. So really the subcomponents of that panel were utilized differently, but the end result was the same amount of utilization of all of the components together. Other examples where we saw that were that the use of reflexive ionized calcium went up considerably, but ionized calcium paired with a BMP dropped. And when you add whole blood calcium also dropped. And when you add these up, it actually results in no meaningful change in the use of that lab. Similar examples for troponins and reflexive chest pain. And the one exception that was favorable is that MAG and FOS dropped in utilization with no corresponding increase anywhere else. And so actually, if anything, we saw a modest improvement in the utilization of a test that, at least from a clinical perspective, I think is probably overused. And then we saw a couple notable increases. The one on the left-hand side there is the urine culture and screen. I think this has something to do with the way reflexive cultures were obtained at the time of go live, but may represent still an opportunity for improvement, but a several 100% increase in the use of cultures, which is not an inexpensive test. And then Puget Sound Blood Center 3-day holds. So we did see a decrease in the use of type and cross, but this is interesting. This is a test that wasn't even in LIS before Cpoe go live. Only a few people on labor and delivery knew that it existed. It was being ordered appropriately. And all of a sudden, when you could search for it, people who had no idea it existed previously started ordering it. And we saw a dramatic rise in the use of this test that nobody needed prior to that point. So what I want you to walk away from this very high level analysis is that the high volume testing was largely unchanged, except for we got a little benefit on MAG and FOS, and probably have some performance improvement projects to tackle around urine cultures and 3-day Puget Sound Blood Center holds. But really, the idea that Cpoe created the waste outside of those few examples probably isn't the case, and so we need to keep looking at how we can refine the system or perhaps use report cards to drive down high volume testing utilization. But I think there's a lot of opportunity in that lower right-hand corner of the plot there. Those tend to be send-out tests. They're some of our highest cost tests, and a small absolute increase in the utilization could really create a lot of waste. And so what we need to do is we need a tailored approach that tackles why something is being wasted. And it may be different for a high-volume test versus a send-out test versus a scenario where the clinicians could be performing better pre-test probability calculations, or where what we're seeing is repetitive testing of something where we need to help clinicians be reassured that that sort of repetitive pattern isn't needed. And it's not going to take one of these approaches. We're actually going to have to do everything. This is an all-out attack where we're not going to solve the waste problem that we have here by applying one solution across the entire system. It's going to be condition by condition. So let me show you some of the conditions where we can make modest change, but it doesn't amount to much until we do this across a lot of different problems. So imagine you're the ward medicine attending receiving sign-out from your colleague on a patient with mild acute pancreatitis. On chart review, you notice multiple pairs of amylase and lipase trending the resolution of her disease, and you wonder, first of all, why are they trending this with anything other than an abdominal exam? But second, you're wondering why they were both ordered in the first place. And you go back and you find that this started in the ER, that an ER intern ordered the abdominal pain workup power plan and selected everything on it. So CBC Chem 7, LFTs, amylase, lipase, and urinalysis. They just went down the row and they checked everything off. And we want those tests available because certainly in the evaluation of pancreatitis, one of the two is likely to be helpful. And in the evaluation of trauma, where a viscous injury is under consideration, the amylase is useful. So we can't remove that from the catalog, but according to the American College of Gastroenterology and others, if you're looking at pancreatitis, the lipase is really the preferred test for a handful of reasons. And so I embarked on a really tiny but tidy quality improvement project with the help of colleagues in the ER and Noah and Brian and others, with the assumption that we didn't need both of these when we were trying to work up pancreatitis. We could get by with the lipase in virtually all circumstances, and that it was the power plan's design that was facilitating this waste. We did a pre-post study 3 months before and 3 months after, in which the sole intervention was just to remove amylase from the ED abdominal pain power plan, but we left it there for the trauma surgeons who needed it in the trauma power plan. And the outcome that we measured was just the rate of simultaneous amylase and lipase orders. And I'll tell you that at least at UWMC's ER, all of the amylases were being ordered with the lipase. So nobody was ordering them as a standalone test. So basically all amylase use here was waste because we don't see trauma, and every patient who had an amylase already had a lipase. This plot shows over time the use this is UWMC, and I'll show you Harborview in just a moment, because their ordering patterns are very different due to the trauma population. But we order 50 to 60 lipases per week. Amylases, we order 5 to 10. Before the intervention, 14% of lipases had a wasteful amylase attached to them, and afterwards 9% did. So that means that those 9% of individuals were taking the extra trouble to go search to add the amylase onto their order set. But this is statistically significant, and we were able to achieve the same thing at Harborview. There, the ordering pattern is very different. Amylase is ordered in much higher volume because of the trauma population, although the people who are ordering amylases often don't order a lipase at the same time. So there's only 22% overlap between these, or testing of both of them. And afterwards, we were able to drop that to 17%, also statistically significant. And I think you could believe that these baselines are not subject, they are variable, but they're not subject to some obvious secular trend. So what did we achieve? Well, maybe not a whole lot, but I think the principle embedded in this case study is still important. We were able to shift the unnecessary amylase use in the ER from 113 per month to 81. If you ask our finance folks, that saves about $3,000 a year. I know if I ask you for a capitated test, you might just say that saves nothing, or a couple dozen blood tubes. So I realize that the impact here is even less than that. But what's great about this intervention is it took almost no time. It took a few emails to the leadership of the ER and to our computer programmers. We had this dropped within a few days of initiating this project. And what we're assured is that this doesn't bother clinicians. We got no complaints and no alert fatigue. But the problem with this kind of intervention is we're going to have to do thousands of these to chip away at the problem before we can eventually say we don't need one more phlebotomist, or we can order fewer blood tubes this month. But it might be the way that we're going to get there and still keep clinicians on board. So where else could we see this kind of a project coming to fruition? Well, imagine this case. As the Associate Medical Director for Length of Stay Management, Brian asked me if we have such a thing. We indeed do. These are all real cases. You're called to examine the care of a patient who stayed almost 6 months on a surgery service, and during the chart review, you discovered that the patient had a 125-hydroxy vitamin D level drawn every week for 18 weeks. And you start to wonder, how did that happen? You go back and you discover that the surgery intern at the time of initiation of TPN was advised by the nutritionist to follow a vitamin D level. They searched for vitamin D and clicked off the 125 instead of the 25. Okay. And this spurred some investigation of what are we doing with vitamin D? And as you know, there are two forms to test: the 25-hydroxy, which is applicable for basically everybody in the Pacific Northwest. It's not really an inexpensive test per se. The actual costs of providing it add up to around $75. And then there's the 125-hydroxy, which is really only for specific patients with hyperparathyroidism. And it's not indicated to test both forms at once. And when we were on paper, we usually weren't. But here's what Cpoe did live. And this graph is courtesy of Noah. This, I think, tells a really compelling story about what Cpoe did to this specific test, which is that in the months before go live at both of our two hospitals, with UWMC on the top panel and HMC on the bottom, we were ordering 1 or 2 of these a month. And then when Cpoe went live, it shot up at UWMC, and a few months later at Harborview, the same thing happened. And now we're testing 20 to 40 of these a month. And incidentally, about half of these are being ordered with a 25-hydroxy as well. And part of what's going on, if you talk to residents after the fact and sort of investigate what the thinking was, is that they're searching for these things and they don't know the difference, so they just select both and figure that it'll get sorted out later, right? A nutritionist will help them. And of course, this does represent a little bit more use. Although we can't get rid of 125-hydroxy vitamin D testing, we did, according to our finance folks, our use of this test went up by about $30,000 per year. So it's not small amounts. But this is what the ordering intern is faced with when they type in vitamin D. They get both. They're in alphanumeric order. So the test we don't want them to get is the first one they see. And there's no guidance unless they click on the info tab, but we know that that's not what our busy interns are doing. I don't think that we have this problem licked yet. We're in the process of studying how could we make a usable solution to this that still lets the endocrinologist, who knows what they're testing, get what they want without hassle, but guide the intern who doesn't know what they're doing to the test that they ought to have. And I'll tell you, we did this before. It was the front clerk of each of our wards, somebody with either a high school or an associate's degree, saw the words vitamin D scrawled on a piece of paper, and they knew which one to get. And they sent the right thing on the blood slip down to the lab. And you take somebody with 10 more years of medical training, and they mess it up. So we need to help these folks. what we're in the process of doing is in a minimally randomized and completely unblinded way, putting one of our 2 hospitals with the nomenclature where the purpose of the test is actually embedded in the test name, and one of the hospitals where we defeat the problem with the alphanumeric ordering, where we move the 125 that's making that appear first to the end of the test name. And we'll see what we can do. We're probably not going to squash all of this waste, but we hope that we can make some headway. What we're unfortunately not able to do is take the search mechanism that's the root cause of this problem and refine it. This product by Cerner is not up to the par of Google and other search engines that we're accustomed to day in, day out. It doesn't do search analytics. We can't tell what people are looking for and try to rename things in a more dynamic way. It doesn't have a PageRank function to say, well, the last 10 people who searched for vitamin D ordered this, so I'm going to put it number 1. It doesn't have typo correction, so if I type in VTMIND, I get nothing because there's no order that's misspelled that way. And there are no cookies. It can't say, you're an endocrinologist, you know what you're doing. I'm going to give you the full panel, and oh no, you're the intern on CT surgery this month. Let me just give you this one test. This is what you want, right? And so we don't have that sophistication here, and unfortunately we have to build the kinds of workarounds that I've been describing up to this point. And we have to build a lot of them. All right, well, what about alerts, right? We could solve some of these problems with alerts. Imagine you're the lab medicine resident on call when a physician phones to ask that you process a stool specimen for C. diff. It had already been rejected because it was too formed. As you explore the request and wondering why they're sending it again, you notice that the patient had a negative cell culture 4 days ago. And now you think, well, even if this were an appropriate specimen to process, is it even likely to be positive now? And why did they order the cell culture in the first place? Because as we all know, the PCR is the preferred test due to its great test characteristics, its rapid turnaround. But prior to this year, Cpoe search gave no priority to the PCR over the cell culture. And in fact, if you went and surveyed interns who were ordering this, what you would learn is they knew there was a difference between them. One took longer, and maybe you were supposed to do 3 of them to rule out the disease, so let's get both now, right? Was kind of one of the myths floating around, driving the use of both of these at once. And what we found when we dug a little bit deeper was that over 10% of tests were occurring within 1 week of a prior test, and the yield of that practice is especially low. In a positive index test, it's never indicated. The patient should be on treatment at that point. And if it's on the same day, what that usually reflects is communication failures within the team, that intern A didn't talk to intern B about, I'm going to order it, no, you're going to order it. And even when the index test was negative, only about 1.5% of these turned positive in the following week. So it's a different problem there. It's about the level of concern the clinician has for the patient. They might not know about that test, but oftentimes they do. And they continue to express concern about the patient's condition, and it's driving their behavior. But one of the things we recognized is that the first step here was really to simplify the ordering and to try to drive people away from the test that was not appropriate for most circumstances. So our step 1 was to bring in infectious disease, microbiology, virology, medicine representatives, and to get clinical consensus that the C. diff culture toxin should be removed as a standalone order. You can still, it's still embedded in the enteric panel, and you can get it by calling the lab directly. But really, this did reduce the use of this test fairly swiftly. And what I thought was interesting is that it really didn't trigger any controversy. Nobody's complained about this. And what that suggests to me is that there are probably other obsolete labs lurking in our order system that we should question. One of the ones Jeff Baird and I are working on now is can we eliminate CKMB in favor of troponin, which has great test characteristics. We just need to invest the time in working with our cardiology colleagues to push this sort of an agenda forward. And oftentimes we'll find that people are quite receptive. But for the problems that didn't relate to the cell culture, we built a series of alerts for each of the problems that might manifest. If it's a duplicate test or a test is in processing, then the alert just went out to say, we've already got this, basically, just wait, and if you click OK, it's removed. So this is a hard stop where the order is not able to be processed. If you had a recent positive test, you'd get a warning that would say, make sure you know about this, make sure your patient's under treatment, and you don't need this now. Also a hard stop that removes the test, although it gives an out and says, if you can think of a good reason, please call the lab medicine resident and we can enter it manually. And then if you have a recent negative as the index test, it warns you that the chance that your retesting will turn up positive is about 1.5%. And it's not a hard stop. So the default exit from this alert will eliminate the order, but if you uncheck the box and decide to proceed, then it'll go ahead and process the order, but it does fire a request for why. So it asks the clinician, what is it that you were hoping to achieve? Since this system went live in February of this year, we've had about 400 alert events just at UWMC, about 300 at Harborview. And just the UWMC data is that for the circumstances where we had either a duplicate or an existing test in processing, 100 of those times we were able to prevent an unnecessary duplicate test. One time there was a legitimate reason why a specimen had not been handled properly, and the residents involved called down to the lab and it was added as desired. So an override rate of 1 out of basically those 100. We stopped 30 tests that were following a recent positive. And the bulk of these, and it doesn't add up to 400, I'll say, but in part because some of these, if multiple team members try to fire the same order because they're probing to see, can I get this? Can you get this? I didn't count that. That's really just one event. So these are sort of one patient on a single day, basically. And by the way, you see that a lot. You see the timestamps will go about every 2 or 3 minutes for about 4 or 5 times, and then they give up. So the prior negative in the last week, we had 185 of those, and 105, or just over half of these, were overridden. And the positive rate of these was 1, so less than 1% of these were actually adding a new diagnosis. And it's a little harder for me to know with certainty that the ones that we didn't obtain were safe to do. We don't know of positives within the subsequent week, but if somebody's discharged and readmitted with C. diff to an outside hospital, I might not be able to know about that. But I think the override reasons tell a lot of the story about what's going on. These are some direct quotes. This isn't scientifically rigorous, but I think these are representative. It's things like multiple risk factors, persistent fever, diarrhea, immunosuppression, ongoing diarrhea, persistent diarrhea in the setting of neutropenic fevers, a lot more stool, high-risk patient. And I think what this boils down to is 2 things. Clinicians are not sure when the diarrhea just keeps going. Should they be nervous about C. diff? When can they call it antibiotic-associated diarrhea? But the other piece of this is that gut instinct of, this is a lethal diagnosis, I can't miss it. This is a high-risk condition in a high-risk patient, and I'm not willing to tolerate a 1.5% risk of being wrong. And I don't think that we're going to eradicate that. I'm not sure that we should, even though the numbers don't bear out that the people who ordered this turned out to be correct in most cases. And I think it highlights the difficulty of implementing decision support in high-risk conditions. We were able to reduce some waste. The most successful elements of this were the portions that dealt with duplicate tests, where we have very high certainty that we're stopping a behavior that's not medically useful. But there are a lot of challenges to guiding decisions in high-risk conditions, particularly this one where I'm not aware of any specific guideline that says the IDSA doesn't have a rule somewhere that you can't retest C. diff within a week. And we have to respect the fact that not just the academic culture in the defense of medicine, but the overall culture of medicine is one that doesn't have a lot of tolerance for risk, and maybe if it was your loved one receiving that care, you might not either. This sort of project also has implications for institutional safety monitoring. When we push the standard of care out to a lot of people in a high-risk condition, we have to build the tools to monitor what we've done. This isn't true for every alert, but if we're going to change something that might hurt a patient in the long run, we need to do that. The good thing is that we have the Amalga tools. In this case, we did build this to provide ongoing monitoring. And I think there are opportunities for refinement. Maybe the text of that alert, which was crafted by Paul Pottinger and Susan Butler-Wu and myself in a room, doesn't really resonate with every intern. We might be able to do better. But what I want to argue to you is that we can't rely on an alert for every wasteful habit. First of all, we don't really have a good sense of what works. We don't have a national clearinghouse that's all that good. The results from single center studies are not generalizable in every case. There are very few randomized trials, and these actually are very costly interventions. This took about 6 months to be built, the C-diff project. That's not because a programmer needed 6 months to do it, but because we really only have 1 or 2 rule programmers. They're pulled in 50 different directions, and they have this really precious resource. They're the few people who can code in this arcane Cerner command language. And so either we buy add-on packages from Cerner that cost a lot of money, or we pay for our in-house programmers to customize, and it doesn't happen quickly. And the other cost is the clinicians who have to interact with this. And this is not trivial, and it may not be apparent to all of you, especially those of you who don't practice clinically. But what we know is that the EHR has really changed the way physicians' time is spent. This is a time motion study from Hopkins of their residents just last year, and they found that they only spend about 12% of their time with patients, but now spend about 40% of their day interacting with the EHR. It's a dramatic shift from what they were doing with paper. A community emergency room published a similar study in which they found that 43%, almost half of their shift is spent on data entry, and only a quarter is spent with patients. It takes 4,000 mouse clicks to get through a 10-hour shift in the ER. Physicians can't tolerate a mouse click to resolve every possible problem that comes up with their order. And when we do, we face a lot of alert fatigue where the important alerts are ignored. This is data just published by Tom Payne and Alex Bryant, one of our medicine residents, that looked at 4 days of medication orders and found that 13% of them triggered an alert. Now, clinicians, when they saw drug allergy alerts, overrode them 91% of the time, and drug alerts 95% of the time. Now, this is actually the refined system. What we got out of the box from Cerner, we've disabled the least useful alerts already. So if you can imagine practicing on the wards right now, 1 in 8 orders you enter is going to fire an alert to you that about 95% of the time you're going to ignore. And that leaves you in the jeopardy that the other 5% of the time you're just going to click OK and ignore that one too. So we do have to get this right. Alert fatigue is real. It does lead to burnout. We have now large studies establishing a correlation between the number of EMR features that are turned on and an inverse correlation with job satisfaction, and that those physicians who are practicing in time pressure environments are actually getting burned out by this and leaving practice. And contrary to 5 or 10 years ago, where things like malpractice concerns or dealings with insurance companies topped the list of why physicians were dissatisfied with practice, of the top 5, now 3, according to an AMA and RAND study, relate to the EMR. And so we're being bled to death by 1,000 paper cuts of alerts, reminders, and difficulties of interacting with the EHR. And we have to really focus on the usability to make the adoption go right. So what other tools do we have? I'm about 2 slides here from closing, and I'll mention very briefly some of the other ways we can solve these problems. We can make formulary changes, although sometimes these elicit controversy, as we saw with thrombophilia testing. When it was pulled, the neurologists at Harborview were really disappointed. They thought they needed that for young stroke patients, and so there's an avenue for them to get that. But everybody else has been diverted away from testing that's really not indicated in the inpatient environment and ought to be led by a hematologist out of the hospital. Or some of the work that I've participated in with Dan, where we took away the serotonin release assay and made it a reflexive test, really helped to create that channel of low resistance that it wasn't being ordered simultaneously with the hit antibody, but subsequent to by somebody who really knew what they were doing. Other mechanisms we have are report cards. I know Patrick talked about that in the preceding lecture, and randomization tools. I think this is really exciting. We've now built some mechanisms in collaboration with Cerner that we believe we have ways to randomize users to receive one order set or another, or we can do multi-arm designs. We're finally going to have some of the tools to demonstrate in our own practice setting in a randomized way what sort of usability features might actually work. Just to echo what I'm sure Patrick showed you is that at least on medicine, we've been using these report cards to tell teams how much they're ordering CBC, Chem7, MAG, and FOS, and it's presented weekly. Again, the downfall to report cards is you have to have people who care and look at them, but we are fortunate to have that. Our chief residents are inserting this into morning report, and at least my understanding of the Harborview data is that we had about an 8% sustained decrease in use of those labs. And so there's probably some opportunities to expand this approach because it's non-interruptive and it catalyzes physicians' excitement about delivering the right care and being competitive without actually interrupting what they want to do for the patient at that specific moment. So I'll summarize the high-level points I'd like you to take away. I think it's very clear there's substantial waste nationally in healthcare, but also at UWMC. And we need, for our own survival, in fact, to address this waste. Decision support tools have potential to refine the way clinicians order tests that may not be needed, but we're often hamstrung by our vendors. Their tools lack sophistication and flexibility. We're going to have to build workarounds and internal solutions for a lot of these. And those solutions need a theoretical model. You have to go out on the wards and talk to residents, find out what are they ordering, how did they get there, which power plan did they use, which search feature, and start to replicate the clinician's reasoning and workflow before we make changes to help lab utilization. And also use that reasoning to select the right tool for the job. It might be an alert, it might be a power plan redesign, it might be a new report, but a thoughtful approach is probably what's going to allow clinicians to adopt that and change. And when you add this all up, there are hundreds, probably thousands of projects ahead of us. And so I'm excited for any opportunity to collaborate with you. If you have heard this talk and are stimulated to address an area where you know there's waste, reach out to me and I'd like to collaborate with you. And that's all. Yeah.
Great talk. This is wonderful work that you're doing, and it sounds like in collaboration with a lot of the faculty in our department. So my question, so obviously lab testing does have cost and increasing cost. My understanding is that's still a relatively small sliver of the overall costs in medicine. But the consequences of maybe ordering the wrong test and getting a false positive result in terms of management can have very large costs in healthcare. And so my question is, are you looking at not only sort of waste and sort of reducing unnecessary tests, but also potential maybe targeting specific tests that may be associated with high costs if you get a false positive or false negative result, for example?
Yeah, that's a really great question. So to paraphrase, the labs that we order don't necessarily account for a substantial portion of the total cost of care, but they have implications for further management that may be very costly. The number one driver of cost in the hospital is length of stay. Just occupying a bed is about 50% of the cost of our average stay. And so I think that there's an opportunity to provide a lot more oversight with that specific concern in mind as we select targets. And I'll give you an example where we made a very outsized benefit out of a small change. So one of the problems we had with the management of heparin-induced thrombocytopenia is that the cost of bivalirudin is extraordinary. I mean, it's thousands of dollars per day for this infusion to run. And if you're a clinician who's decided that you're going to wait for the serotonin release assay to come back from Wisconsin, you've committed your patient to potentially 3 or 4 more days in the hospital, plus $8,000 to $10,000 more bivalirudin. So the cost of the test isn't the issue, but you're absolutely right. It's the downstream consequences. And what we've seen is that with the project to, and granted, this wasn't the only feature, but when we moved to reflexive testing on the serotonin release assay, and also some other projects in the pharmacy, this last year we were able to trim about $700,000 off our utilization of bivalirudin. So there are major savings out there if you pick the right target. Yeah, Mark.
Andrew, again, thank you for taking this on for such a nice talk. Another kind of savings that's likely, even from these low-cost tests repeatedly done, is blood use. And I wondered if you've had a chance and can model and then see how your interventions influence blood transfusion.
Oh, yeah. So the question is, the other cost of these tests is diagnostic anemia, and that if we bloodlet our patients too much, we're going to transfuse them, which is a cost and a risk. And the short answer is that I haven't personally, with local data, attempted to model that, but I'd be excited to. I think one of the things that's going to make that a little bit hard is that we're seeing in a lot of clinical entities over the last 2 to 5 years reports of large randomized trials, multi-center trials, demonstrating the harmful effects of liberal transfusion strategies. And so what a lot of clinicians are doing that they didn't do 5 or 10 years ago was to transfuse less anyway. GI bleed, cardiac disease, critical illness, they're just sort of piling up, and the evidence is really firm, I think, that we don't need to reach a hematocrit of 30, that 21 will do for just about any condition now, and maybe lower. And so I bet there's going to be a secular trend in our blood use that has something to do with shifting clinician attitudes and not as much to do with diagnostic phlebotomy, but we should talk about it some more and see if we can come up with a project.